Welcome to New Directions and Approaches in the Management of Patients with HER2-Altered non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Joshua Sabari from the NYU Langone Health Perlmutter Cancer Center in New York City to discuss cases and key presentations and publications in one of the most exciting new areas of oncology research, particularly the recent approvals of two HER2-directed tyrosine kinase inhibitors, zongertinib and sevabertinib. In the first part of this three-part podcast series, Dr. Sabari discusses cases presented by Dr. Mark Jeng from the Memorial Sloan Kettering Cancer Center in New York City. To begin, Dr. Jeng presents a 96-year-old woman with a history of light smoking and a resection 5 years ago of a stage 2A HER2 exon 20 insertion mutant adenocarcinoma, followed shortly by disease recurrence in the bone, treated with TDM1 and then TDXD for 5 years, now with disease progression.
We switched her very recently to zongertinib, and she's been on this for about 3 or so months now, and she's doing really, really well. We are managing her effusion with the Plerex, but hoping that once the more response to the zongertinib kicks in, we may be able to remove the Plerex catheter. She had mild diarrhea just for a couple of days, but that was the only side effect that she's had so far. This lovely 96-year-old has been doing great on it. And one question you may bring up with the faculty is, we do have these really two great TKIs that were approved back-to-back, zongertinib and sevabertinib. So when they're trying to decide which of these agents to use, how would they use it? And what are the side effect profiles that may lean one way or the other? The most exciting change in the last couple of months is zongertinib received an expanded approval to be now used in the first-line setting. One nuance I would say is that zongertinib and sevabertinib are only for HER2 TKD mutations. That is, the majority of the mutations are in the TKD region. But you can get mutations in HER2 that are activating that are outside of that. Which one would you be reaching for in that setting? I would ask them, can you just clearly define what is the difference between overexpression, amplification, and mutation? How do you test for each of these things? What are the different cutoff points? And how does the biology of this differ in lung cancer versus in breast cancer? I would ask them a little bit more about what is the phenotype of patient you might see for some of these alterations. For overexpression, we have trastuzumab deruxtecan. What are some of the response rates we're seeing for overexpression? What is some of the durability we're seeing with that? If you have overexpression without a HER2 mutation, is a TKI helpful in that setting?
So as you can see, a million questions here, but why don't we start out with these sort of basic questions he was bringing up in terms of HER2 testing?
Yeah, so Neil, a phenomenal case, 96-year-old, shows you how much we have advanced lung cancer over the last, couple of years with mutation testing and now novel therapies. So in any patient with lung cancer, I'm getting broad panel next generation sequencing, and that's going to identify the HER2 mutation by next generation sequencing. And these are uncommon. These occur probably about 2 to 4% of lung cancer. We also do look at amplification, which is copy number gene alteration, right? And we can identify that by NGS. We can also identify that by FISH. And then lastly, it's still critically important in 2026 to get immunohistochemistry. And that is specifically for HER2 overexpression. Remember, overexpression is protein expression on the cell surface. So these are different entities, right? Mutation is different than amplification, different than overexpression in this population.
So again, of course, there's a lot we have to say about these TKIs, but just first to kind of get a broad question, and then maybe we'll get into another case, which is my eyes got opened very, very wide when I sat down, I think it was last summer, with your colleague, Dr. Haymock, and I walked away going, whoa, when you started talking about these TKD mutations and these TKIs. And correct me if I'm wrong, it sounded a whole lot like EGFR and ALK in terms of what's going on here. Am I overreading it?
No, Neil, I think you're spot on here. I mean, this is, a true mutation that is activating that we can now target effectively and durably with tyrosine kinase inhibitors, with pills. So, historically, when we thought about HER2 mutations, we didn't have any acceptable targeted therapies. Clearly, chemotherapy was a standard of care. More recently, trastuzumab deruxtecan, a HER2-directed antibody drug conjugate, was showing us impressive response rates around 50%, with progression-free survival in that 9 to 10-month range. Here, with targeted therapies, tyrosine kinase inhibitors, in the frontline setting, we're seeing 77% response rate and median progression-free survival here north of 12 months. So I do think we're moving into the EGFR territory. Clearly, there's still a lot that we need to do and improve upon for this patient population, but it really is an exciting time in the HER2 mutation lung cancer space.
And I think that's the area that we need to update people on. I find even investigators outside of lung haven't even heard of this. Even the breast people, it's really interesting. But anyhow, maybe you ought to touch a little bit on two other questions that he brings up. One is the question of other mutations other than TKD. Do they respond to these TKIs, and do they respond to TDXD? And then what about overexpression? Maybe just remind us what we know about TDXD and overexpression or amplification, and also these TKIs.
Yeah, so HER2 mutations are quite broad, right? Again, we identify them on NGS. The most common one that we see is this YVMA. That's the mutation that our patient here in this case has. We probably see that in about 70 to 80% of the HER2 mutations. We call it a TKD, or tyrosine kinase domain mutation. It's in the sort of active machinery of the gene that produces the protein. But you then have mutations that can occur outside of the tyrosine kinase domain, so S310F and others. It's interesting when you look at medicines like zongertinib, for example, or sevabertinib, which is another HER2-directed TKI, the activity is quite high in the tyrosine kinase domain region. But when you look at mutations outside, the response rates are far lower, in that 30% range. So more work needs to be done on this patient population. Important to note that non-tyrosine kinase domain mutations are quite rare. They probably make up 20% or so of the HER2 mutations in this population. You asked also about HER2 overexpression, and we know a lot about that from the breast cancer space, right? A lot of our drug therapies are approved based on HER2 expression. We also do have approvals in lung cancer for HER2 overexpression by IHC. Remember, trastuzumab deruxtecan is approved here in patients with IHC 3+. What about, Neil, the TKI, right? Do the TKIs work in the HER2 3+ population or the HER2 overexpressed population? We don't have significant data there yet. So the label for zongertinib and sevabertinib is particularly for HER2 mutation. If we're dealing with overexpression, there are trials that you can enroll patients in, but we don't have sufficient data to utilize these TKI in that patient population.
All right, so here's another case from Dr. Jeng, a 63-year-old woman, former smoker with the same HER2 TKD mutation as the first case.
She's one of our cases that was diagnosed with baseline brain metastasis. She got SRS up front and then was started on systemic carbopemibevacizumab for about a year or so before having systemic progression. Her second-line therapy at this point was TDXD. And she was on this for about 8 months or so. One of the side effects that we were noticing was the thrombocytopenia. And then she progressed systemically. We went back to the chemotherapy, but added immunotherapy in this case, treated about less than a year. And then she got a fourth-line therapy with TDM1. But because she progressed quite quickly in less than 6 months, and at that point we had a zongertinib, we were able to switch her to this now fifth-line systemic therapy, which she continues to be on to this day. She is doing overall quite well. She's off of the in-play completely. So potentially bringing up what is known about the intracranial efficacy of each of these, TDXD and zongertinib.
Where else did they have the disease?
Yeah, also had bilateral lungs, bone as well.
Did she actually have an objective response to zongertinib?
She did.
Any questions for the faculty?
Let's say you had someone who were treated with chemotherapy first, progressed with brain metastasis. One question would be, which one would you sequence next, knowing that brain metastasis is the issue? What would you choose, TDXD or zongertinib?
So any thoughts about this case?
Yeah, this is another very important case. It brings up a couple of really interesting issues here. As a young patient, she has, treatment up front with the chemotherapy alone, no immunotherapy. So in patients with the, HER2 exon 20 insertion, YVMA, again, the most common mutation, should we be giving those patients immunotherapy? Neil, how effective is immunotherapy in EGFR and ALK mutant non-small cell lung cancer? And what do you tell, clinicians out in practice?
So, yeah, we're going to actually get into that with the next case. This lady seems to be having a response, an objective response to zongertinib. He had mentioned before about how you choose between these two approved TKIs. Can you comment on that, and also what we know about CNS activity of these TKIs versus TDXD? We know in breast cancer, I'm not sure how much data there is in lung. In breast cancer, clearly TDXD has good efficacy in the brain. So what about these TKIs?
Yeah, important question. For zongertinib, we had a cohort of patients with active, untreated CNS metastases, and we saw about a 44% response rate. So extracranially, the response rate is higher, right, in that 70% range, intracranially in that 40% range. So you do need to monitor the brain closely with this agent. For cevabertinib, which is an EGFR and HER2 exon 20 inhibitor, we have not seen data on active, untreated CNS mets. You brought up trastuzumab deruxtecan, right? That's the HER2-directed ADC. We have seen in prospective trials 40% response rate in the brain. So I think across the board, we need better CNS active agents in this setting.
Another aspect of this case, I'm curious in general also, what's been seen in terms of tolerability issues with these two TKIs? Obviously, the other TKIs we use, osimertinib, et cetera, alectinib, lorlatinib, a lot of them do have tolerability issues. What kind of tolerability issues or side effects come up with these TKIs? And also, in terms of this particular case, do you see any hematologic myelosuppression? Because this patient had they actually had to treat the thrombocytopenia on TDXD, and then it got better on zongertinib. So seems like less cytotoxic or hematologic toxicity. But what do we know from the trials?
Yeah, I think in general for HER2 TKI, we tend to worry about, GI side effects, things like diarrhea, potentially rash. We don't necessarily see hematologic toxicity like we do with some of the ADCs or chemotherapy. So zongertinib specifically is a HER2 specific inhibitor, right? So it does not hit EGFR. It spares EGFR wild type. So you see very little skin toxicity, very little GI toxicity. 50% of patients did have some diarrhea, mostly grade 1. I think there was only 1% of patients who had grade 3 diarrhea. Just to put that into context, 1 or 2 loose stools, a week. Grade 3 diarrhea is, 6, 7 loose bowel movements in a day. So we don't see that with zongertinib. We do sometimes see small changes in AST and ALT, and it's important to monitor the liver function test, every 2 weeks for the first 12 weeks. But, Neil, this is one of those agents that is very well tolerated, similar to osimertinib, for example, or alectinib in my clinical practice. Cevabertinib is a little more differentiated in that it has both EGFR and HER2 targeting, so it does not spare EGFR. You do see higher rates of GI toxicity, higher rates of diarrhea. Upwards of 20-25% of patients can have even significant diarrhea with cevabertinib. Importantly, when you compare both of these agents to, trastuzumab deruxtecan or other chemotherapies, you do not see that hematologic toxicity. So for this woman with a platelet count of 90, you would not expect that with the HER2 TKI.
So how do you decide right now with both? I guess first line, you only have one, but in the second line and beyond, you have 2 potentially available. It kind of sounds like maybe you would go with zongertinib first because it's less toxic, or any reason to think that there's a difference in efficacy?
Yeah, so in the second line setting, you have accelerated approvals for zongertinib and sevabertinib. Those are both, tyrosine kinase inhibitors. We also have an approval, an accelerated approval for, trastuzumab deruxtecan, a HER2 ADC. I still sit down with patients and discuss all three of these agents, and I explain to them the efficacy data, and I also explain to them the quality of life, side effect issues with these agents. I think when you look at the efficacy and side effect profile head-to-head with these agents, zongertinib to me looks far better, right? Response rate in the second line setting, about 71%. You see very good progression-free survival at 12.4 months. And as we mentioned, it's overall a very well-tolerated medication. I try to keep, trastuzumab deruxtecan in my back pocket for, later on down the road. Why? Response rate's a little bit lower, PFS is a little bit lower, and there's also that, chemotherapy-like side effect from the deruxtecan, the topo-1 payload. When we differentiate sevabertinib and zongertinib, similar efficacy in my opinion, but I do think zongertinib is far better tolerated as it's HER2 selective.
So, of course, obviously with TDXD, you also have concerns about ILD. What about, I guess we should also point out that I don't think there's any direct comparison between TDXD and the TKIs or the TKI. It's all indirect. But what about responses to one TKI after they progress on the other?
Yeah, it's an important question. We don't have a lot of data on sequencing the TKI, so we don't know what the response rate would be for sevabertinib post-zongertinib or zongertinib post-sevabertinib. We do actually have data, though, post-trastuzumab deruxtecan, so we know that zongertinib has over a 40% response rate, even in patients who've had prior trastuzumab deruxtecan. But, Neil, you bring up a really good point here that we have no head-to-head data of, trastuzumab versus TKI or any of the TKIs head-to-head. So what we're doing is cross-trial comparison, and we're taught not to do that, but we tend to do that for a living.
Well, I guess we also keep in mind, too, we just presented a 91-year-old woman who had a 5-year response to TDXD, so maybe the numbers don't look as good, but certainly a lot of activity. All the cases I've been hearing have had TDXD first, so maybe that's going to change. But any data on TKI first, and what happens if you use TDXD next? Do you see responses after they progress on a TKI?
Yes, we're starting to see data emerge now from some of the academic centers. You do see activity post-zongertinib with trastuzumab deruxtecan, and that's very reassuring to me because these are different mechanisms of action, right? Zongertinib or sevabertinib are tyrosine kinase inhibitors, whereas, the trastuzumab deruxtecan is a chemotherapy or a guided chemotherapy in that setting. So I think it's important, to sequence these agents appropriately. Right now in the frontline setting, zongertinib remains the only agent approved as a targeted therapy in this setting. Trastuzumab deruxtecan approved in the second line. But Neil, there are 3 ongoing phase 3 trials right now, all comparing to chemo and immunotherapy, interestingly. So there's a phase 3 of zongertinib versus chemo-IO, of trastuzumab deruxtecan versus chemo-IO, and sevabertinib versus chemo-IO. So I think that data will really help us understand what is the best agent in the frontline setting.
So you're going to love this next case. 85-year-old man, never smoker, PD-L1 is 70%. It's got the same exon 20 TKD mutation we've been talking about, and no carcinoma of the lung, status post-resection. Here's the case from Dr. Jeng.
He had resection in 2022 and actually had 2 years before it recurred again to the bone. Because of the high PD-L1 score, we opted initially to treat with pembrolizumab, but really had this primary progression in about 2.5, 3 months there, and it was quite widespread. And so then we reached for TDXD. This again was before zongertinib was approved. And after 4 cycles, we had what we called a metabolic complete response there. So it was quite exciting. And now he is on his 27th cycle of trastuzumab deruxtecan and has had a really good, not just complete response, but a sustained response. So I think this is one of the patients that we really are excited to see the efficacy and the durability of this treatment for some of our patients. I brought this up partly because, we are still learning about which patients may respond to immunotherapy versus wouldn't. I think we're more comfortable for other driver mutations like EGFR and ALK. We really don't use immunotherapy anymore. So one question I can see for the providers is that, again, if you saw the same patient with a PD-L1 of 70%, are you going to be reaching for that immunotherapy in the first line setting? Or are you going to be saying this patient is a never smoker and we have other HER2-directed therapies? Would you be reaching for that instead? So I think that's a great question for them. If we saw this patient again and progressed on first-line pembro, and now you have all three options available to you between TDXD, zongertinib, cevabertinib, what are you reaching for and why? For the faculty, do you mind overviewing some of the ongoing phase 3 trials or new trials for any of these agents with zongertinib, cevabertinib? Are we going to take a page from the EGFR mutant lung cancer world where we add chemotherapy? Or because we have trastuzumab deruxtecan, what about combining those two with TKI? Just like in EGFR and ALK, we know that use of TKIs perioperatively, particularly in the adjuvant setting. Do you think that the same principles will apply for HER2 TKIs? I will say there is a trial with zongertinib in the adjuvant setting that we are opening up at MSK soon. It's already open.
So a lot of questions there. Yeah, really interesting to think about these TKIs in the adjuvant, maybe even neoadjuvant setting. But, in terms of this question of high PD-1 and targetable mutations, maybe we could just start out and get your overall take on that question. I mean, obviously, as he mentioned, I think, with EGFR and ALK, there's a pretty strong sentiment about not using IOs, if not ever, but certainly not very early. But sometimes I'm not sure about some of the other ones like BRAF or MET exon 14. Maybe you could just kind of provide an overview of all the different situations where you use targetable therapy and when you've got KRAS in there, when you hold off on IO, and where do these TKIs fit in?
I think, immunotherapy has this tantalizing opportunity for durable, long-term response, should I say, cure in some patients. And I think that's why it keeps on coming up in this driver mutation positive patient population. In a patient with an EGFR or an ALK fusion, even with high PD-L1 expression, we know the response rates are quite low, the durability of response is low. And most concerning, Neil, is that these patients can then have significant immune-related adverse events when they then go on to the correct therapy, right? A tyrosine kinase inhibitor in the next line setting. So, not only do they not respond, right, but they have very poor outcomes with regard to toxicity. I still recall a 38-year-old gentleman who had an EGFR mutation, got immunotherapy in the front line because his PD-L1 was 100%. This is as a fellow. And the patient, didn't respond, then went on to osimertinib and had horrific colitis and could not really tolerate the effective therapy for them. So where does that take us into the HER2 space? Well, for HER2 exon 20, first and foremost, about 50% of our patients are never smokers. In the never smokers, I would recommend against using immunotherapy. I think the paradigm exists similar to what we see in EGFR and ALK. But in a patient who's a smoker, who has a PD-L1 of 70%, Neil, I don't know if we know that data yet. We're going to better sort of understand that as we look at, phase 3 studies. You mentioned MET exon 14 and BRAF. I cut my teeth on those mutations trying to understand, is immunotherapy inferior to targeted therapy? And it's still a very mixed story. So for me, is the patient a smoker? Would they benefit in general from immunotherapy? And if the answer is, they're a never smoker, I usually tend to avoid it. Targeted therapies are also better tolerated, in my opinion. And you can always use immunotherapy in the later line setting should you need it.
So, and, also thinking about the first line situation, we do have zongertinib approved. We're going to take a look at some of the data. But how about if I say, I'm kind of hearkening back to even actually before osimertinib, I think with erlotinib and gefitinib. But somewhere along the line, everybody realized it doesn't matter what the PD-1, it doesn't matter very much anything. They're going to get one of those TKIs up front. And then as time went on, we talked about adding to it. Do you think we're there right now with zongertinib?
It's interesting, we've talked about, can we combine zongertinib with other agents? And I think it is well tolerated enough that we can do that. one thing that we've all talked about, and again, this is not approved, but this is something that we're discussing, is combining zongertinib with trastuzumab deruxtecan, hitting HER2 in different ways. And I think that's a really interesting opportunity. But the idea of combining chemo and immunotherapy and a medicine like zongertinib, I would worry. I would worry about the potential untoward side effects. Remember, the rates of, ILD, interstitial lung disease for zongertinib were extremely low. Only 2 cases reported. So, potentially they would be safe to combine, but I'm not sure we gain that much with adding immunotherapy for this patient population. But it's an important question, and I think, especially in our patients who have a heavy smoking history with a high PD-L1, do I feel confident that there is no role for immunotherapy in 2026? The answer is no. I still think we need to gather that data.
All right, I'm going to try to flip my question around a little bit and say, you have a patient with metastatic disease presenting for first-line therapy. You know they have this TKD mutation. Can you describe a situation where you would not want to use first-line zongertinib?
It's tough. It's hard to think about a case where I would, preferentially not use zongertinib because of the efficacy data and the, sort of safety profile. You think about, different patient populations. If they had significant, CNS metastases that I was concerned about, I may consider doing upfront radiation and then potentially zongertinib. But I don't think that, trastuzumab deruxtecan is better than zongertinib with regard to CNS activity. So, I can't really think of a case where I would select, trastuzumab deruxtecan over zongertinib at the moment.
And I know that, it's still early. We want to get a lot more data, but obviously we saw with EGFR and then ALK, the move towards in patients with brain mets who don't have any symptoms, particularly if they would require whole brain, to hold off on radiation therapy, and again, assuming no neurologic symptoms, and try systemic treatment. Do you think that that's a reasonable approach in a patient who are about to start zongertinib with brain mets? Would you want to wait a little bit if they had small brain mets and asymptomatic?
I think if the lesions were small, sub-centimeter, no vasogenic edema, and patients were asymptomatic, I'd feel very comfortable starting zongertinib, 120 milligrams PO daily, and a short interval scan, a 6-week scan. If they achieved response in the CNS, and I've seen that in patients in clinical practice, I would continue. If they've had any evidence of progression, I would do stereotactic radiosurgery to those lesions. Now, Neil, if a patient has a symptomatic lesion, right, or they're on steroids, or they need anti-epileptics, that's the patient I may not feel comfortable, waiting that 6 week. I may want to radiate up front and then start the zongertinib on the back end.
Yeah, particularly I think if they can get SRS, as opposed to whole brain, even with EGFR, I see people doing that. This concludes part 1 of our program. Special thanks to Dr. Sabari and to Dr. Jeng, and thank you for tuning in. Stay tuned for part 2 and then part 3. This is Dr. Neil Love for New Directions and Approaches in the Management of Patients with HER2-Altered non-small cell lung cancer.